This week on the BackTable podcast.
All of us, we're probably at our peak. Like we're used to things. Either we can see patterns, we can get through cases. It's all second nature, but eventually that will slow down. And proactively thinking about just second part of your career, it is hard because a lot of people talk about legacy, and I've tried to really take that out of my mind. It's not about me. I don't want my name up on a plaque. It's kind of nice if you have it, but I'll be long gone. What I want to know is that the things that I've helped build, that those people who are now doing them have the right resources to do them. But just as quickly as people remembered us, we're going to be gone. And I wish more physicians could hear that, because I see that around retirement, the disappointment, the fear of leaving what your identity is. We have to go deep into that one day. How do you separate your surgeon identity from your human identity?
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and once again with me, Dr. Amy Park. Amy, good to see you again.
Hey, how are you?
I'm good. And you were just back from Canada, and I'm going to Canada soon, but we've got another Canadian on the show. It's always a pleasure. Dr. Sony Singh, welcome to the show.
Oh, it's a pleasure to be here. And I'm curious as to why you were both in Canada too, if you wanted to share that.
Well, I'm going to AGL. And
of
Amy
course.
was just at Augs.
In Vancouver. Welcome. Everything's 30% off.
That's what I said.
It's such a great city. I am so excited to get back there. I mean, there's nothing I don't love about Vancouver.
Well, we welcome you with open arms.
Oh, I love Canada.
I know I went to Michigan, so we were in Windsor a lot, and we've been to Toronto. I mean, yeah, huge fan of our buddies up north. But this is not a show just about Canada. This is a show about OBGYN, and we don't do a lot of OB, but this is one where we have a little bit of crossover. And so I want to introduce our guest. Sony is a professor, department chair of OBGYN at the Ottawa Hospital, MIGS surgeon, fellowship director of now it's complex GYN surgery, MIGS, whatever we're calling it, fellowship.
Exactly.
He is co-founder and former executive director of the Canadian Society for the Advancement of GYN Excellence, so CAN-SAGE, and a prior AGL board member as well. And so on top of all this, in your spare time, you are also managing some OB issues as well. So we're excited to have you on the show. And as we like to do when our guests first get here, is tell our listeners a little bit about yourself, sort of how you got to be where you are and how you got to be interested in this topic.
Well, thank you for having me, and I really do appreciate it. And I appreciate everything you're doing to get the word out on the many issues that are both professional, but there's always a little bit of a personal connection, and I love that. And I recognize many of the people who've been on your podcast, and I'm happy to share my story, but many of them have influenced my career, and looking forward to having our chat today. So yeah, I was born in Canada, and I ended up in medicine, always taking an interest in actually women's health and advocacy, who knows what drives us all to do this work, and just moved along the path into medical school and then into residency. And at the middle of residency, I started taking interest in surgical fellowships. But at that point, so this would have been around 2004, there wasn't much. So I attended the first AGL, I think it was called the Resident and Fellows course. And you had, Mac Monroe and others who were there. And I just fell in love with this subspecialty. At that time, it was not a subspecialty. It was just this thing these people were doing. And so I thought I was going to eventually become a urogynecologist, and ended up sitting and meeting one of my first mentors, a minimally invasive gynecologic surgeon, self-taught, named Nick Leyland in Toronto, Ontario. And he took me in. I was the underdog. I didn't know him. I wasn't from Toronto, and ended up doing a fellowship with him, which was amazing, focused on endometriosis and hysteroscopy. And then just to get more experience, I ended up giving my CV out at an AGL meeting. It all connects through AGL. And my next boss called me up from Australia while I was sitting at the Apple store in Chicago, right on, the Magnificent Mile. And he called and said, "I found your CV in the trash. Do you want to come and hang out with us in Australia for a year?" And without asking my wife, who was pregnant, I said, "Sure."
Wow.
So we all moved to Australia, with a guy named Alan Lamb.
Oh, yeah.
Yeah. So I did a second fellowship, and then rest is history. I came back. I was given the baton to start our first minimally invasive gynae society here in Canada called SMIG, SMIG, Society for Minimally Invasive Gynecology. Not a good name. And so I wrapped that up and retired, but nobody took the baton to take that over. And then I ended up starting the Canadian Society for Advancement of Gynecologic Excellence, CANSAGE. And now that's just flourishing. And again, retired from that to focus on our department to advance women's health more locally in our Ottawa, the capital of Canada, and try to grow that. So obviously we'll get into more info, but that's sort of a overview of my history to this point in my training.
No, I love hearing that. And I love hearing it. You know, the way we get to be where we are is never a straight line. Not everybody gets to go around the globe. But so I have to ask, how did your CV get in the garbage? What was the...
So, I was very keen. And when I saw Alan present on endometriosis, like we were doing good endometriosis, but Alan's presentation, he was just excellent. He's just a gentleman, an excellent surgeon. And at the AGL, to see the way in which he presented, I said, you know what, just in case you're ever looking for a fellow or anything else. At this point, I already had a job in Toronto. And I met many other folks you've had on and others throughout my years. But he basically just was looking for a fellow and probably had a pile of papers and was going through it. And he said, I was about to throw this out and decided to call you. But I do advise that you talk to your significant other when you want to move. Now, in retrospect, it was the best move, but we had a brand new daughter. Amelia grew up in Australia, but I would never give up that experience again. Doing training abroad is difficult at the beginning, but unforgettable by the end.
No, it sounds incredible. I spent a semester in Sydney in Coogee, UNSW, and it was like, I've been waiting my whole life to go to Australia, and it did not disappoint. It was absolutely... It's a magical place. And I sort of always occasionally scan, depending on the political climate, we'll just sort of scan like the Australian GYN surgery jobs just to maybe get back that way. But no, we're excited to have you here. And we're going to talk about something that I'm not as familiar with, and something, frankly, that scares me to death in some ways, which is obstetrical surgery. So talk to us a little bit about how you ended up doing that. I mean, again, every hospital does a little differently, and we've had some guests come to talk about it a little bit. But so talk to us a little bit about, as a MIGS surgeon, how you got pulled into this.
Well, my thesis and the proposal to all of you today is that the minimally invasive gynecologist is the perfect person to take on obstetrical surgery for many reasons. And it's not a hospital-based thing alone, it's a countrywide thing. In Canada, the folks who do the obstetrical complex surgery going forward, for the most part, aren't the maternal fetal medicine specialist, is no longer the gyne-oncologist. They get to sleep more often at night because of us. It's us. It's the minimally invasive gynecologist. And if you think about it, the way we know anatomy, the way we understand the pelvis, the way we understand complex surgery that preserves fertility is unprecedented. The fertility folks try to help you get pregnant. The gyne-oncology folks, when they see a issue in pregnancy or a complication, the uterus is coming out. And so we really are set up because we know the anatomy, we know the approach. And so when I got back in 2007, was recruited to Ottawa, immediately it started with our laparoscopic cerclages, which I helped Nick. He basically developed this approach, which is now the largest number of cases done in the world, in Australia, where we taught it as well, for doing a laparoscopic abdominal cerclage. We've got huge numbers being done in this way. And so I showed that there in Australia and then brought it back. And that was our first way to start looking at obstetrical surgery, either when their patients are pregnant to help them or while they're pregnant. But then it quickly evolved into who's going to take care of the placenta accreta. You know, our rates of C-section in the US and Canada are 30 to 40%. It's crazy. And so you're going to see patients with cesarean sections in their past and either going to, take them down or fix the complications like cesarean scar niche, or you're going to see someone land a pregnancy in that scar. So it'll present as a cesarean scar pregnancy, and or if it continues, it'll become an accreta. We started to develop a team, and I was on my own at the beginning. And then as years go by, as of now, after almost 20 years, we have a group of 5 who focus on working these cases up, working with maternal fetal medicine, and we do the surgery from beginning to end, managing that patient and preserving the uterus when we can, of course. But it is all based on the same principles. know your anatomy, know your approach, and do a good job.
I find it interesting because I went to Ages in August. They had a perioperative meeting, and I agree with Mark. It's an amazing place. Between Canada and Australia, I don't know. It's a toss-up. That's amazing. They're both such great places. But the Australians really were so, I didn't even realize ultrasound is one of the subspecialties. Actually, they told me that Urogyn is not as popular because it's not remunerative as much as the other subspecialties. I think, there's Matthew Leonardi, there's a lot of people who have trained in Australia and go back to Canada. But it is interesting because as a specialty in terms of fertility preservation, uterine preservation, doing the myomectomies and whatever else, and doing the ultrasound is sort of uniquely positioned. I hadn't thought of it that way before.
You're the perfect people to do this, and I'd love to know how much you do as well, but you're doing it. So if you're doing a myomectomy to preserve the uterus, that patient, is going to end up getting pregnant. And if they have Accreta, right, that was because we did that surgery to help them get pregnant, and that increases their risk. If a patient, is coming in with uterine adhesions, they had an obstetrical intervention, a D&C, that caused that. Why not get in front of it and try to prevent that? So at each stage, we have a role. The difference, I guess, is that here in our system, which, as you know from Jonathan's talk before, publicly funded, privately administered, is that we really only have a few of us relative to how many you have. So when we develop these teams in these bigger centers, we've become the people. And right now, the main things I see are retained products of conception with complications that then develop into Asherman's. I have every couple of weeks, I do a full day of Asherman's. Like, that's how popular the service is, because it's just huge volumes of these issues that previously weren't diagnosed. Cesarean scar pregnancies, and then issues in pregnancy such as placenta accreta, or who does the myomectomy at the time of your cesarean? Like, if you've got a patient who you didn't get to or you hadn't seen, is it going to be the maternal fetal medicine person, or are they going to try to leave it in? They cut the incision and try to stuff it back, So we're trying to say that you can do, there's so much to do. And don't even get me started on the endometriosis and pregnancy story, because that's massive. The increased risk of complications on every level, seeing spontaneous hemoperitoneum, which I've seen in pregnancy. These things are all there. So I think it's just a matter of time. And we don't have the turf war that maybe other systems do. Gynae oncologists don't want to do this, but in the US, I know they do a lot of the placenta accretas. The REI folks might want to do a bit more. Here, it's just nobody wants to.
I don't think people want to do it here either. I think it's just evolved into that. But I think that, like you said, it's more of a workforce issue. I mean, and you're a regional center, I'm guessing, so you have more.
For 1.5 million people.
Yeah.
We have, for a while, we only had 2 MIS people for 1.5 million. So now we're up to about 4 or 5.
Yeah, that's not enough. I mean, you're getting called in if there's going to be
Exactly.
a section. And I mean, it's a challenge. I do think that it's interesting because we had Brett Einerson on from Utah, and he is MFM, and MFM at Utah has a whole placenta accreta spectrum team. I think that's unusual, though. I mean, I think other programs are trying to develop that, but the fact that MIS is doing it at your center. I mean, Mark, can you think of any other?
Throughout Canada.
Oh, throughout Canada.
Canada.
Yeah, I actually talked to Paya Pasek about this, and that's the MIGS team at U of L in Louisville do the placenta accreta spectrum stuff. Like they are the team that does it, and that's what he told me as well. Which I was like, wait, why would you ever want to do that? Don't you like sleeping? But yeah, I mean, historically, I think the default in the U.S. is onc.
Yeah, I agree.
And we actually had one of my colleagues give grand rounds this week on sort of the future of GYN oncology and sort of what GYN oncologists do in their 30-ish% benign surgery, even though we've got 2 MIGS surgeons where we are. And they're also doing all the Accreta stuff on top of that. And they're spread pretty thin, right? And there's plenty of cancer to go around, unfortunately quite high cancer rates where we are and low resourced areas and advanced cancer presentations. So, I mean, I'm sure there would be interest. I don't think we have the bandwidth. I'm only 30% clinical. So I think between 1.5 MIGS people, it'd be tough to own that. But I think it's interesting. I'm curious to understand sort of how you guys got there.
Mark, let's first start with, I like to sleep as well. That's why I gave up obstetrics. So I gave up obstetrics only 5 years into it. And I remember, you might hear this, but to one of my colleagues who's close to retirement now, I reminded him, he said, how are you going to survive without obstetrics? Because that's what's well remunerated. But, of the three things that I, you got to have passion. It's got to make you some money if you're academically interested in it, doing research, et cetera. So I think leaving obstetrics allowed me to pursue all those other things. So I like sleeping. So the ideal placenta accreta case happens during the day, well organized, around 35 to 37 weeks if you can plan it accordingly. That made a big difference. And so that allowed us to book them. And the team and the camaraderie that you develop from this is incredible. Like anesthesia has been all over this with us, maternal fetal medicine. It's really, really great. And I guess that's part of being in a tertiary academic acute center. Amy, back to your point, I did sacrifice a lot early in my career where I was coming in and driving in, and I live, only 15 minutes away from the hospital. But as time goes on, I'd recommend to everybody to build a team. And now I'm actually missing it a bit because my teammates they're working together, always a junior and a senior surgeon, but they're doing well. So, they're running with it, but we have some good backup now that it just doesn't have to rely on one person. And when you build that, this is a high risk surgery and, high chance of maternal morbidity, hopefully low mortality in our systems, but it's not zero. And, you just go ahead and do it. And if we have time, I'd love to share a couple of cases with you, but, I don't know how many times in your career you've had to do CPR or how many units you've had to transfuse as a maximum in a case. And, those are things that I'm not proud to say, but it shows you just how scary things are. And we actually have a lot of debriefing that we do in these cases because it takes a mental toll as well. But I wouldn't give up any of this past work that I've done because it's so rewarding and needed.
No, I think about, what we do, and I do think we do big surgeries, right? I think as MIGS surgeons, I've taken out a 13-pound uterus. We do, multiple myomectomies, and, these are challenging surgeries with significant blood loss at times. So it's not that we're not used to that to some degree, but I'm not dealing with that stuff on a regular basis, right? I think about, I'm not a trauma surgeon, right? We don't deal with that level of complexity. And I don't know if that's something that you were doing because you'd still done obstetrics and that transition happened then. Were you doing it while you were still doing OB? Because again, I haven't done OB for about a decade. And so it would definitely be a pretty steep learning curve for those of us that have not done it in some time. Was that transition relatively smooth for you?
You make a good point because I was doing OB at that point, and I think that definitely aligned with what I was doing and what I was seeing. That's why I was attracted to focusing on gynecology because I didn't want to be up all night catching babies, frankly, which I think should be done by midwives or family physicians. My own wife saw a family physician for all her deliveries. And so I think there was a good opportunity there to make a difference. And so I quit OB to focus on this. But you're right, there is that learning curve in the transition. And I always say you need a senior and a junior surgeon to develop this. But it is a team. It's never alone.
When you are talking about developing this approach, and it sounds like it's been adopted nationally, what are some of the best practices? You said you have anesthesia, you had MFM, presumably NICU is, neonatology is part of the team, perfusionists, whatever, like scheduling
all of the above.
Scheduling all of this, like having the backup, having the team, having the OR ready. Sometimes these are emergent cases, but what have you learned? Because I remember when Brett was on, he was saying, they're also a regional center. And that's another thing that's also hard because he was like, people come in from 4 hours away from Utah and they're literally living, in a hotel or whatever, Ronald McDonald House, like for months away from the rest of their family, just in case the bleeding starts and there's something bad.
The psychosocial aspect is massive. Again, although at this point you may not want to do it, but I think your audience may not need to because you've got to practice a set. The reason I think it's a good argument, the reason we developed it here is there was nobody else picking this up as their main mission. So we help build those teams that you're talking about. And we had a speaker from Baylor. Oh my God, he's going to kill me because I forgot his name. But the main person he's an MFM at Baylor who talks about placenta, Accreta. And we did an international or national symposium. And, that really also helped me define what our team needed to be. So building the team. So MIS people are great at building teams. You already do it. When you talked about those cases, Mark, that you're not doing those alone. You've got a good assistant. You've got an anesthetist who's willing to work with you, right? How many times have you been in the OR and somebody's like, just make a big cut and get it out, right? So you need the right people, the right team, the support in the hospital. And so it's all of those things, Amy, you said we have. And I think building that team allows you then to deliver that. But the next, after placenta Accreta, which is now, I think, established that we do them at one center, we get the diagnosis with ultrasound. The next aspects that have come out are the cesarean scar pregnancies, which have been underdiagnosed, undermanaged, that hemorrhage from a D&C. So managing hysteroscopically miscarriages, dealing with the scarring or preventing the scarring. And there's a lot of other stuff, the obstetrical surgery. So Amy and Mark, I want you, and I think this is within something that people would do. I'll be the OB, I'll deliver the baby, but I want you to come and help me do the myomectomy at the same time, right? Because it's big there. And I have this case coming up about in a regional center. I'll drive 2.5 hours or 2 hours away or more because she has a large pedunculated fibroid coming off the fundus, the patient does at the time of cesarean. And instead of making her have 2 surgeries, we'll go and do the cesarean. I'll let the OB do that, and then I'll do the myomectomy. So I think there is an opportunity. Adnexal masses, what do you do with a really ugly ovarian mass? As an OB who doesn't do it all the time, I want you guys there. Can you please come and help me get this out? And, first inclination, well, you're there, just do it. But most OBs may not feel comfortable and they may not know how to take down the adhesions or the scarrings or the approach. So I think it's an area of interest. And my final point is I know it's popular because when I was on the board of the AGL, I organized one of the first surgical OB programs in Colorado. And we had our local gynae oncologist in Colorado who did the placenta Accretas also present. It was standing room only because most people still do OB and GYN in the US and Canada. And so I think there is a massive need, but we should be the leaders. I have no qualms about saying that. It's us because we're probably better at saving the uterus than people are used to taking it out.
Well, how do you deal with the increased vascularity? Because I remember these cases from residency, and it was just just looking at the mesosalpinx, these vessels are this big.
Yeah.
Do you just clamp it for?
It's the same way you deal with it all the time, though. I know you do. You think the pregnancy
She's a Urogyn. All of hers is like capillaries. She's like, atrophied vessels, 6-gram uteruses.
No, I took a 130-gram uterus out earlier this week, but
130 grams.
Anyway, it's not that. That's nothing for you guys, but a
cuterus.
Yeah,
they're
But the urogynecologists are the other ones who do this procedure in Canada. Actually, they were our. If it wasn't gyne-onc, it was a urogynecologist. It was my teachers in urogynecology who did it back when I was in training in Western Ontario.
Yeah, well.
Amy wants nothing to do with this.
You know what? I actually, it's funny because it is, I think we are natural allies because we are the benign gynecologic surgeons. Like I was joking about the 130-gram uterus, but it was, it
was smaller.
It wasn't that big. Yeah.
It's just basically the techniques to Morsley to control the bleeding, the bulldog clamps, all the other things. And now Urogyn has gone more towards hysteropexy. Aaron Brennan gave this big talk at OGS it was super interesting about how hysteropexy should be the standard. It was very thought-provoking. But in terms of just taking it on and the regionalization of care for these complex surgeries, it sounds like you're arguing that MIGS is uterine preserving benign gynecologic specialty in terms of just the natural focus and bent and the ultrasounds findings, etc. Do you find that, MFM, I'm guessing, takes care of more like the fetal side, and then in terms of surgical planning, MIS is?
Yeah, so they take care of the mum as well, like in terms of we had to work together a lot on that, optimizing anemia, just everybody just order IV iron, That's one of the big messages we have in getting them all primed and prepped. But we work wonderfully together. We don't have the politics in Ottawa that other centers have as well. There's some centers where they argue about who's going to do the cesarean to bill that, then do the hysterectomy. We don't have that politics. So it's just, you know what, we work together as a team, and we just want the best surgeon to do the job that's appropriate for that case. And so I guess for your positions both, I think the issue is you identify people early in their career who want to lead this, who want to make it, and encourage them to go do fellowships or extra training or build the team. That might be the other thing that we are empowered to do as leaders is how do you create that team at your center if you don't have one? So for people listening, it's paramount that your center has an obstetrical surgical service. Like, you need it. So if I can ask both of you, do you both have obstetrical surgical services? Like, if I had a cesarean section and I needed help with a pelvic mass at the time of cesarean, is it an organized thing, or is it just, whoever's available?
I mean, we have a little different setup because we have the big academic hospital where it's trauma, it's cancer, it's babies. And then we have a hospital a mile down the road where we do our total joints, plastics, benign GYN. And so we're just not physically in the building for a lot of it. Now, that's not something we couldn't, operationally fix, but because Onc is like next door or downstairs and they have fellows, they can kind of walk over and do some things. Now, oftentimes popping over to do a 4 to 6 hour case is not convenient for anyone. I don't care how far away you're coming from. It's something that should be scheduled and managed. But no, we don't have a surgical service. But I think, listen, we've talked about the name change, and it's something that we've been thinking about for a long time. MIGS doesn't make sense, right? We are all minimally invasive surgeons. What is the pathology we're managing? And if it's complex benign gynecology, this would fall into that, right? This is not cancer. This is a benign disorder. It's complex. And looking at numbers more recently, just for hysterectomies at our institution, in 13 years, I've done, I think, 5 abdominal hysts. And 3 of those were because urology or colorectal surgeons had opened the belly and said, hey, can you pop this uterus out? Like, I converted a couple early, but, I have 99% MIS rate, which is great, but I don't do a lot of open hysterectomy. Now, I've done, open myomectomies more frequently just because they're getting a C-section anyway. And now we're more slitting through an incision. But we've really gotten away from that as MIGS surgeons. And, should our training involve more open surgery? And this is amazing to both develop and maintain that training while providing a necessary clinical service. So I think when I first started, I went to some of the gynecologists and said, listen, I'll come in nights, weekends, open cases. I don't want to lose it, because it's one of those things that if you don't do anything very often, it's easy to get not as good. So I'm all in. I think this makes a lot of sense. I think the challenge is starting it, that the hump of like getting those of us that don't do it a lot back in the game. That's fixable.
Mark, you make a great point. It would be a great way to get open cases in and encourage people. But I guess my thesis and argument is not necessarily to change what's working for everybody, but rather adding in another realm that I think should be part of and own, because we know how to do conservation. So if you see a dermoid cyst at the time of cesarean, argument is just leave it, right? That's what we always say. If you see a fibroid, leave it. But as a GYN who has extra training, wouldn't it be nice to do a beautiful cystectomy at that time? And back to Amy's point, use techniques that mitigate risk because you're aware. You can tie off vessels, you can temporarily clamp them. So put aside the placenta accreta stuff. The other area is management of miscarriage, retained products, cesarean scar pregnancy. So that's hysteroscopy for a lot of it, or laparoscopy combined, but understanding what the ultrasound shows. And that has become a huge thing that we are trying to promote worldwide with the Global Congress of Hysteroscopy, as well as our own region. And we are the ones to look at the ultrasound and say, stop. Don't go in this patient who's had 3 DNCs, still has retained products, with another DNC, right? You need experts who are going to look in the uterus, clean it up, and then manage the complications. What's an AVM or not an AVM? People are so confused. I feel again, who's going to take care of that? Who is the defined protector of the uterus in early pregnancy? It's not the MFM. They haven't even seen the patient. Generalists, unfortunately, are trained to do a DNC blindly without looking at the ultrasound. And gyne-oncs not there, so we need to develop that aspect. So our latest thing that we're trying to put out is jump in front of everybody who's just going to go to another DNC and say, stop, let's be conservative and careful and thoughtful. If somebody got lots of blood flow, does she really have an AVM? Does she need an embolization or not? And in some cases there may be or not, and understanding all that. So that too, that's, again, where's that objective in the AGL complex fellowship aspect? And I think it is going to become a bigger issue. Women are older. Cesarean sections in the US are 35% to 40% now. So I think we're going to see more of that.
Yeah, I think this is part of what I see as like, urogynecology went through this whole evolution as a field 20 years ago, like defining it from, because a lot of, Cleveland Clinic was part of this whole push of training people how to do slings and doing the kind of surgery that we're doing, pushing apical suspension procedures. The liability, I think, pushed a lot of people out of it. And people didn't understand what was unique about urogynecology. MIGS, it's even more, or complex benign gynecology or gynecologic surgery, whatever you want to call it. The Venn diagram is very overlapping, in terms of carving out your expertise, because a lot of people don't understand what it is. Like Mark walked that walk, fought that fight, it's still going on in many places. They just don't understand. And the fact that you became chair at your institution just speaks to, the respect you gained as in building these programs.
And also because nobody else wanted to do it, by the way. But that's a whole nother talk about leadership.
No, I'm not gonna let you minimize that. I agree with Amy. I noticed the same thing. I don't know that there are many. I don't know how many MIGS CMOs there are, and I don't know how many MIGS chairs there are. I think it's one of those things that, somebody with a focus on benign gynecologic surgery. That's most people, most patients, right, have to deal with that. Like, hopefully you don't get cancer, and, there's some patients that need urogyn help, but like almost everyone has touched a gynecologist, a benign gynecologist at some point in their lives, one way or another. And I think that's something that seeing you in a leadership position like this should be encouraging for others, and should be you're a role model for a lot of us out there that see what you're doing. So I don't want to minimize that.
Well, I appreciate that.
Do a job is different than doing it well. And clearly what you're doing where you are is doing a job well. So I don't want to let you minimize it.
Yeah.
Yeah. I don't know if it's my andropause or not, but I'm blushing. So thank you very much.
Well, no.
Yeah. Well, I think also just what you've been saying has resonated in terms of, I see how this evolved in terms of trying to bridge this gap and fulfilling this need. You're obviously going, commuting out to these regional centers. You're stepping up to the plate on these really hard cases. I think it's super ballsy to go, and a quarter of our cardiac outputs are going to the uterus and the ovaries by extension and during your third trimester of pregnancy. So it is not insignificant in terms of the potential blood loss. But I just wanted to go back to what you were saying in terms of these, setting up these programs and the logistics and getting the buy-in and bringing people over to your vision. How were you able to achieve this? Was it just nobody else wanted it, or you just, wore them down with your persistence, or how did that happen?
Amy and Mark, in Canada, everybody just agrees with you. Everything works out well. There's never any drama.
Well, I believe it. I believe that everybody.
I wish it was like that. I think leadership, and we have a course on this. We're doing it, TED sponsored our course along with Eddie Vetcher and a couple other folks. Kara's on it as well.
I noticed that. That's going to be a great one.
On leadership. And I think, Amy, what you're talking about is what you had to go through in urogyne. We forget gyne-onc went through the same thing. Remember, everybody was doing gyne-onc surgery. And when I was back in training, we would take out pelvic masses and say, oh, we're fine. Gyne-onc had to fight as well to be a specialty. So I think it's a lot of persistence and resilience. And I think, Mark, you would agree over this lifetime, because you're the youngest on this call, but still pretty old.
I just look the oldest, unfortunately.
That we have made a difference altogether. This community, like Amy, seeing you, I didn't even know you were going to be on this call. You're like a legend, right?
No.
And the fact that you said the word ballsy on this is, I'm very proud to hear that from you. We all had to work through it. And I think we're on the right side of history. The right side of history is that expertise should be celebrated. And when we know that's the better path, people and resistance is going to come up in front of us, and we're going to just have to keep plowing through. I read an interesting JAMA article that it takes 17 years to make
Change yes.
to practice. So ultrasound, when we first started doing expert ultrasound in 2007, right? And you're just hearing about it now. Overall, we were doing expert endometriosis scanning way back when. And, here we are almost 18 years later, and it's still not standard of care. People are still getting ultrasounds where we don't know, that they had all this deep disease.
That's why I'm in hospital administration, because I didn't like waiting 17 years. Tell me the right answer now, and I will do what I have to do to make it policy that we do the right thing. Or we'll change the incentive to put money in the pocket of folks that do the right thing. And that to me was like the impatience that I have for waiting for people to do the right thing. Like, I ain't got time for that. These patients deserve better.
Good for you.
So that's honestly like my why in doing this is like, let you guys do the research, let you guys be the experts, tell me the right way to go, and I will make sure that we get the right outcome that we want. Because assuming people will do what's in the patient's best interest takes 17 years, right? So I think our patients deserve us to be a little bit more impatient in that way.
Mark should be at this course. Mark, that was awesome. More MIGS people need to take leadership. We are again, thesis, MIGS people should be in leadership positions, and some urogynecologists too.
I've given talks on leadership. I was lucky to work with at Michigan with Tim Johnson, and he gave a leadership curriculum for our fellows, and it changed my view on all of it. I mean, honestly, it was life-changing. Talking, he had a football coach come. He had Ari Weinzweig, Zingerman's Deli CEO, come and just talk about these things that we don't talk about those things in those terms of medicine. It's hierarchical, and this is the right answer. And if you're wrong, you're terrible. And all these things that allow us to do this work. And so you have these ideas and how to operationalize them and how to actually get them to be. And so as you're talking about these things, all I can think about is like, okay, how do we actually take the people that we have now? How do we take the team that we have and sort of transition? I can promise you the oncologists would be very willing and interested in mentoring young surgeons to learn how to do this work to phase themselves out. I have no doubt about that, but you've got to have some interested
That's exactly what happened
surgeons
here.
to do it. I can in my mind, I can see how that transition could be made in a way that would be sustainable. And that to me is why it's exciting. I think, we've been asked to do the C-section scar topics. And I remember that NMFM called me and said, we did this with an oncologist years ago in a big X-lap and it was tiny. So just go fix it. And I'd never seen one. The first one I ever did was just one that I did on my own. And we've done a bunch of them now, but each one gets a little bit bigger. Each one gets a little more complex. And you see that the anatomy is the same. And I understand where my uterines are and where the ureters are. And I understand what spaces I can get into. And yeah, I mean, I see the sort of the dots connecting in that way, and you're convincing me. I'm listening.
Well, let me just ask this, because just as a pan view, of course, I don't doubt your expertise, and I agree about
You're allowed to.
No,
we're allowed to.
No. I'm just saying this is the thing that I do worry about and wonder about is how do you scale up? Like you did scale up, but there's, you alluded to the workforce. You built the program from solo yourself to 5, but this question has come up in the parallels of gynonc and like the regionalization of care. High volume centers do better. Like what is the access for people? I know Canada is very population based healthcare. Like when we had Jonathan Solnick on, he basically was like, we're very strict about criteria, pap smears, who gets to subspecialists, et cetera. And so, I just wonder about people who live in more remote areas or not in the city. It's like, are we creating disparities in care there? Or you're doing more outreach? Like, how have you modeled that? Like a spoke on the hub?
Yeah, you know what? I feel like I'm talking to like-minded people. All the stuff you've said is important. First of all, let's talk about the importance, and Mark said it. I think you really have to do internal work that you want to put yourself out of a job. You want to retire at a reasonable time when you are healthy and enjoy your life, and how you're going to build that team behind you that can cover the clinical work. It's not about me. So couple of weeks from now, right before the AGL, there's a case that's going to happen, and I'm not going to be there, but I have 2 of my colleagues. So partnering with your junior colleagues to empower them to get stronger and get better is our moral responsibility and building programs. And that when I look around the country, and I've come from admiring people to now sitting back and being a bit more judgmental, is I don't want to hear from you if you've been doing it for 40, 50 years. I want to hear what system you built to maintain it. And I think that's the questions you're asking, Amy, which is critical. So I think mentoring people, building the infrastructure to allow them to succeed is going to be, and get out of their way to do it. But you do need a critical volume. So that's why it's not everybody. We have this debate every time, and I recognize I have to be careful that I have to support my colleagues, but they need to deliver as well. And this is where Mark's accountability comes in, and being honest with people and building that. And finally, the regionalization. I love the fact that you're talking about it, because we have so much resistance to it, because people are like, well, I'm not going to drive 30 minutes to do an OR. Yet I know across the US, that's become the norm in some big centers as well, because access to OR time is not about just coming to your center, it's going to the people. So working closer to provide tertiary care. During pandemic, I couldn't operate in my own hospital where we only did oncology. So I drove 2 hours away for 8 weeks straight and did tertiary care cases, because Mark said we could do our crazy cases in these outpatient hospitals and maintain that, but it was care closer to home. So I think all of those things, that's the bigger picture. And when you're in the grind as a junior colleague, you could be a senior colleague too, but you're only thinking about yourself or whatever your small microcosm is. We need people who are big thinkers, who are going to revamp the system and make that change. And so, it's all of the above, Amy, what you said.
Yeah, I mean, it's interesting because it's like, the pendulum swings, like, and drawing on the analogy of radiation oncology, like, just seeing what happened with, access to care, like radonc here, we actually do offer brachytherapy, but a lot of places thought that external beam was the answer, and they stopped. And then, my colleagues across town, there was only one person who did brachy. And then when she was out of town, all brachy stopped, and I was like, God, that could happen to what you're saying. These skills could just, you could just leave.
I think about, we have pioneers in AGL, and all societies do, right? You've got people who did things no one else would do, and there's a bit of hubris, and, you have to, in a healthy way, that I'm going to do something that everyone else says is wrong. I think highly enough of myself that people think, Arnie doing a robotic case in Michigan, people stood up and said, no, this must stop. And the same thing I'm sure happened for CY Liu and others. It takes a certain kind of person to be a pioneer, but to balance that with the humility to say, I had my great idea. I can't wait to hear what someone else's great idea is going to be, as opposed to everything that I say now is going to be a great idea, right? And we've met both of those kinds of people. I think teaching people how to lead and the joy in leadership, and I think you said it, phasing yourself out. Like when I was clerkship director or whatever thing I've been in charge of, I wanted to be able to leave town and have people not call me. But if you set the system up in a way that it runs itself, that the people that are doing it know what to do, and you train them to do it in a way that the expectations are clear, that when you leave, no one misses you. And there's a little bit of humility in that. You have to just say, I built it, and I'm okay if no one notices that I'm gone. And if my junior partner takes over and is a star in a program that I built, in a clinic that I built, in a team that I built, in a OR culture that I built, and no one remembers me, that's fine. I don't, it doesn't, I get to sit back and watch that. And I think some of us need different things, but I think that's something that maybe we could talk about more in system building, in like you said, process building, so that when you leave, this change is sustained, this thing you built. And that's where I think teams and all those things and building your...
I was going to recommend a book to you, because it's just, I know we'll have to eventually stop, but I can keep talking to both of you forever. This is like talking to like-minded people. There's a great book, Strength to Strength, which I really recommend to everybody. It's a wonderful book that talks about you being at your peak. So both of you, all of us, we're probably at our peak. Like this is a we're used to things. Either we can see patterns, we can get through cases, it's all second nature, but eventually that will slow down. And proactively thinking about your second part of your career, which is what Mark just beautifully summarized. And it is hard. It is hard because a lot of people talk about legacy, and I've tried to really take that out of my mind. It's not about me. I don't want my name up on a plaque. It's kind of nice if you have it, but I'll be long gone. What I want to know is that the things that I've helped build, that those people who are now doing them have the right resources to do them. But just as quickly as people remembered us, we're going to be gone. And I wish more physicians could hear that, because I see that in around retirement, the disappointment, the fear of leaving what your identity is. We have to go deep into that one day. And maybe that's another podcast, is how do you separate your surgeon identity from your human identity? And all of this relates back to what we're talking about, which is creating systems of excellence and teams. And surgical OB was just one example of where we've done that.
Is that just, I think, are we selecting for that? Is that inherent in our training in this hierarchical, you need to ascend to this sort of like, not even godlike, but like this, the medical pedestals, right? We put these people like, on these places, and part of what this show is to me is being able to talk to people that like yourself, that I put on medical pedestals for being just made of different stuff. And then you chat with them, and they've all had their challenges. And I've referenced this in the show a few times. Getting to talk to John Stagey for a minute, and he didn't know who I was. And he gave me 30 minutes of his time and asked about me. And he was kind of saying, well, I'm dealing with this thing. And I'm like, oh my God, I'm dealing with that too. And demystified it a lot. And it took a lot of the pressure off me, number one, allowed me to take the pressure off myself and just focus on the work. And the other piece is learning to give myself the credit that I deserved without needing someone else to say it, right? That's something we're trained to say. I need someone to say I did a good job, or else I'm not good. And at some point in my career, it was, fighting battles or whatever it was, or wanting someone to say good job. And at some point, I just have to feel like I have to set my own bar and decide, is this level good enough for me? And that's really the only judge that I need to think about in that sense, besides my wife, obviously, who's like the only, that's what she thinks matters the most. But in this work, right, and setting a higher bar, most of the time it's setting a higher bar than others would, right? But at the other point, and then whatever anyone else thinks, it's like, and that's so against my natural way of being. I want constant positive reinforcement all the time. And just to say, I'm going to do the right thing and walk away. And what anyone else thinks is really none of my business in that sense. And that's tough for a lot of us.
It's funny because when I joined the American College of Surgeons, they had these periodic webinars and seminars on how to retire, because this is like a common theme for a lot of surgeons. Number one. Number two is regarding the reinforcement cycle. I do think it's like I had to do some major reframing in my career surrounding those kind of like positive feedback mechanisms and things like that. I do think it can be very detrimental to self-esteem, et cetera, but also leading people to pursue things that they may not necessarily want. But also, like, the third thing is we're realizing that, of course, building the team at work and all that is really important. But, as a husband, wife, daughter, mother, sister, that is where you're irreplaceable. So we always have to nourish those relationships. Like, somebody else could do my job tomorrow, but like... Well,
no, my dad always said, no one ever says on the deathbed, I wish I'd spend more time with the office. But I gave my talk in my grand rounds in residency on wellness and happiness in residency back in 2010. Like, that's a long time ago. And the oldest guy in the room, Mahmoud Ismail, as a MFM, who said, I was just talking to Dr. Moad, who had just retired, GYN, who had, trained everybody at University of Chicago. And he said, Mahmoud, we screwed up. We worked too hard. We spent too much time at work, and he had all this regret. And I'm a chief resident. I haven't worked a days in attending in my life, right? I'm just like seeing this, reading about it, trying to prepare myself for a career where I'm not miserable. And here's the oldest guy in the room saying, listen to this kid. He knows what he's talking about. Work matters, but at the end of the day, you leave and this place keeps going. And legacy matters to me with my family. Otherwise, like, I don't know that I can say it with honesty. I don't care what, I want to do a good job, and that's enough.
There's a whole article on regrets that surgeons have. This was in JAMA Surgery, and they did a survey, and they said, yeah, and it was like, it was basically like, I wish I'd spent more time with your family. It was like a big number, the scale. Like, it was eye-opening. I think a lot of people looked at it and it was like, oh, I need to learn from this. Like, I know I looked at it and I was like, I kind of knew this. I knew this, but you really realize what that means when you're talking about your day. And what it is like, I did a hard calculation, 24 hours a day. I need like ideally 8 hours of sleep. And I just subtracted all the things, of like how many hours you have to accomplish all the things in a day. And I was like, wow, you really don't have that many hours of like accomplishing, and aligning your values with your time and your attention. It is difficult. And I just tried to read books and be mindful of that, because it's easy to not have that all aligned.
Well, as a department head, one of the things, the secrets that I had to deal with, and Mark, you probably, I don't know if you do this too, you kind of said it already, is I just wanted, for especially the administrative side, the surgery side is hard to, there we really are focused. We're going to, we want the best for the patients. There's no compromise in terms of that. But in terms of the administrative stuff, presentations, going to the AGL, my new goal is just to be good enough. I just want to be good enough to get the job done that day. I don't have to be perfect. Perfection is our enemy in many cases. And since I started doing that, I get to bed a bit earlier because I close that presentation that I would have normally spent even extra hours trying to make sure everything is perfect. And it's really helped a lot because nobody notices because you've showed up, first of all. That's just enough many times in the administrative world. And so I save a lot of that energy for our patients and other things. And the other thing that saved my career and probably my life was building a team that it's not about me and allowing it to flourish and trying to stay out of their way. I still get in their way. I apologized yesterday as well when I gave my opinion a few more times, but the team is very forgiving. We appreciate you and we appreciate you've identified that, you're still our senior surgeon who maybe should move out of the way sometimes. So I think yeah. So anyway, I think those are things I wish and impart upon people right now. We should just don't worry about the small stuff is really back to that.
No, I love that and I appreciate that. And that was something, and Amy, just stop me if I've already talked about this, but I took over for a good friend of mine in the CMO role, and I took over surgical supply chain from my boss, right? How am I going to do better than these people who I have such respect for? And how I view leadership now is like they are them and they lead a certain way and they have a certain joy in what they do. And then their time is up. And then when it's my turn, I'm going to do the thing that I do. And I can promise you in 5 to 6 years, everyone will be tired of the way I do things. And it's time for me to succession plan and make sure that once I've given what I can to move the organization to this next place, that someone else that I've prepared, someone else to come in who does the things that I didn't do very well. And to watch that and go, okay, like, because I had to hire someone who replaced me in my old medical director role in the OR, and to watch them be great in ways that I never could and not be mad about it and not be like, oh man, they're just better than me and that stinks. But like, I got us to a point and I brought this person in who's going to get us even further. And it's just a series. It's a never ending, like the infinite game. And this, Simon Sinek book I loved, but like the goal is to keep the hospital open, right? It's not to win. We're not trying to like beat other hospitals and shut them down, right? The goal is for us to continue to provide care to as many people and to do as well as we can. And we have to take care of each other to do that. And you got to put our people first. And so to me, it's being part of this, like getting on the train and then getting off, right? Like it is just enjoying it while you can, as much as you can. There's too much fun stuff in this world to spend your whole time being miserable. It's just not worth it.
And a caveat to all this, you have Amy, you have Mark, you have myself. We're in a privileged space to say this and look back. But for those of you right in the middle of it, those of you starting your career, all we're asking is that you pause and reflect at points that we should have. I should have taken a breather when I was in Australia rather than trying to do that extra 10 projects, right? I should have taken a pause. And, it's hard when you're in the moment, but all we can do is just advise, and it's your journey. But I think as we get older, everything everybody has said, your dad said it and others said it, it's true. It is absolutely true. Nobody's going to pause and say, how many hysterectomies how big was that uterus that you took out? Right on your deathbed. Are they going to say that?
Right on my tombstone. Right. Exactly.
And was it 113 grams, Amy? That was huge.
I certainly hope not. I certainly hope that's not what's on my tombstone. So no, I mean, I know we started talking about something very clinical, but I really love how this conversation went. And this is the stuff that I think about on a daily basis with the teams that I work with and the people that I get to. If we got to be there, we got to do important things. If we're all in a good place and if our heads are all in a good place, then we're going to be so much better at what we do. And this is hard work. And what you do is hard work. And obstetric surgery is as hard as it gets for anybody. And so to have a team that you can do this hard work with, to me, is really such a testament to your skills as a surgeon, your skills as a leader, as a team builder. And I think that's something that I'm looking forward to your postgrad course at AGL on leadership, because I think, and I've known those guys for a little bit too, great roster of people in that course. But teaching people how to lead is something that has become really, at least this point in my life, has been what I believe is the most important work we can do as physicians, because it is a team sport. And if we can't just be running around by ourselves. So I really appreciate your time. You're a busy guy. There's fewer hours of daylight up there, right? So because up north, so it's even more valuable that you spend time with us than us down south. But it's been an absolute pleasure, and I look forward to hanging out in your home country in a couple weeks, pretty soon.
Yeah, let's go have a Canadian beer. And,
yes, please.
Labatt, without the tariffs.
Labatt Blue.
No. I'll get you
No.
not the water beer, not what you're used to.
That's what we drank in Detroit. Was in Ann Arbor. Was a lot of Labatt.
No, I'll
Blue
take you to
ads.
Granville Island Brewery. There you go. That's one
I've
to
been
put
there,
on.
and I'll take you up on that. And they still have that sake place as well.
Yeah,
House-made
I love
sake on
sake.
Granville Island. Fantastic.
There you
Well, I
go.
look forward to it.
Thank you
What
both.
an absolute
Thank you,
pleasure.
Amy.
Thank you so much for coming on.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
And Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Urogynecology.
Show notes and social media by Emma Landenwich and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.